Good Saturday morning to you, everybody, and welcome to the HyperFit radio show. I'm Gary Byron, joined as always with Dr. Charles Guglin. He has spent 30 years as a practicing surgeon in the New Haven area, predominantly at the Milford Hospital, where he was the president of medical staff and chief of surgery. 5 years ago, Dr. Guglin began HyperFit MD to practice preventative medicine rather than reactionary medicine practiced by most traditional practices. He and his wife, Francesca Guglin, operate HyperFit MD in their hometown of Milford, Connecticut. Doc, good morning.
Morning.
How are you?
I'm good. Happy New Year.
Happy New Year. Yeah. How was your week?
Yeah. We were busy. It's good. Busy. Yeah, it's a good week. We were busy. Yeah.
Being busy is good, but when you're on this side of the table and when you're on the other side of the examining table, it may not be so good, right?
That's right. You don't want to be part of a doctor's busy day.
Exactly.
Don't.
Although, I don't know, maybe it could be argued where if someone's coming in there for preventative reasons, maybe that is a good it is definitely a good thing.
Absolutely.
Yeah, exactly.
Most people come into our practice, come there voluntarily.
Right. Well, that's
brought by an ambulance or anything.
That's a real boy. But you've seen plenty of that in your life too, right?
Absolutely. Yeah.
Emergency room stuff.
That's where general surgeons. That's how they feed their children. Is what comes to the emergency room for the most part. Yeah.
Now we never like to see tragedy with anybody. Of course, usually there's families involved and there's nice people who just go through traumatic circumstances. But for a surgeon, how do they look at something traumatic to the emergency room? Is it just I got a job to do and
there's an element of that, but if somebody who's very sick or is dying or anything along that spectrum doesn't touch your heart in some way, then you shouldn't be there in the first place. Absolutely. I mean, and as you get older and you start to suffer the infirmities of age, you start to appreciate what those people are going through also. I mean, that's part of it as well. But, the myth of surgeons especially is that they're somehow inured to the pain and suffering of the people that they're working with. And it's just not true. I've never met a surgeon who didn't have a level. I never met a physician who wasn't empathetic in some way or another, didn't have a well of empathy that they used in their practice. You have to use it in your practice. You can't sit there and talk to a family and advise them in one way or another without putting yourself to a certain degree in their shoes. We've all lost somebody. We've all been sick. I've had surgery several times, so definitely I've been on the other side of that fence, and that helps quite a bit also.
Do you let the surgeon know that I'm one of you guys?
Oh, yeah, definitely. There are definitely some advantages that accrue to letting somebody know that you know what they're thinking.
Treat them like VIP.
Well, yeah. Cops look out for other cops.
That's right.
Every trade you're in, there's courtesies that
Absolutely.
the general public is not privy to. But
Yes.
But it could also be intimidating. Going, I can't tell him this line of.
Yeah. Well, part of it also is there's no such thing as surgery without complications, and so as you're going to sleep, as you're being put to sleep for whatever operation you're about to undergo, what's going through your head is, man, I hope I wake up.
Well, it's so funny that you bring that up. I got a whole topic of conversations I want to get into with today's theme, but I'd be remiss if I didn't go there with you. So. That's probably my biggest fear would be not waking up, not from complications from the surgery, although that would make me a little afraid too, but having either over anesthesia or under. You hear these stories of like, I was awake the entire time. I'm like, my goodness.
Yeah, I'm a little skeptical of those claims. I really am. It's anesthesia, modern anesthesia now is so, the monitoring that you're undergoing, especially for long operations, they're even monitoring your EEG, your brainwave patterns. So if your EEG says you're asleep, you're asleep. There could be some dreaming involved in that sort of thing. An impression before you go to sleep, like, hey, I'm not asleep, and then you wake up with this impression that you heard things and that you experienced things and that sort of thing. But
has that ever happened with you? Did you ever, when you woke up out of it?
No.
You were heavily sedated.
Oh, yeah.
It's not a normal sleep that you're putting in. I mean, because when I go to bed, somebody starts cutting me, I'm going to wake up pretty quickly.
Right, exactly. Okay. And, when I tell people nowadays is a couple of times when I've been under sedation for minor procedures, I've just made an absolute fool of myself. Just blah, 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 blah. I used like talking. So I tell them, whoever's doing it nowadays, I'll just say, look, put me, just make sure I'm heavily sedated because otherwise I just don't shut up. It's amazing. But
there's a threshold, right? There's a window of where they can't go over or they can't go under, right? It's
sure.
Based on your weight or something? Or
it's based on a lot of things, based on whatever your pre-existing conditions are, so on and so forth. I mean, if you're in renal failure, let's say, the calculations are completely different than it is for a healthy 18-year-old. So there's a lot of different factors involved.
Interesting. I'm sorry for the digression. There's a whole itinerary of questions I have for you with today's topic. In the past, you've mentioned testosterone, and you've always, say we'll have to get into that in another show because it really requires the amount of time that a full show would warrant. So let's just start with the very basics. What exactly is testosterone? I know men have it, but what exactly is it?
Testosterone's an anabolic steroid.
Oh.
It's a potentiator of many different systems in the body. First and foremost, it is what determines determines the manifestations of manhood, of masculinity. Not ironically, but it's interesting. A brand new male baby, for the first 6 to 7 months of life, has a spike in testosterone that then drops off to almost nothing until they go through puberty. Nobody really knows what happens. They think that has a lot to do with the sort of, for lack of a better term, the masculine mindset. Let's say maybe it's what turns the masculine part of your brain on. Nobody really knows why that happens, but it's interesting that it does. Women need testosterone, and we'll talk about that in another setting. But women need testosterone also. It's a determinant of many different manifestations of womanhood as well, including things like libido, being able to build muscles, those kinds of things. But at its basic, it is an anabolic steroid that in men is created and excreted mostly by the testicles. Women, their complement of testosterone comes for the most part from their adrenal glands.
I always thought women didn't have. I thought they had estrogen.
They got lots of different stuff.
Wow.
Testosterone's one of them. Yeah.
Why then is it important why do we need to have testosterone?
Well, it again, first and foremost, it's what determines the changes that occur with puberty, everything from development of different sweat glands in the body to hair growth to development of the different aspects of masculinity that we all know, including libido, sex drive, muscle building, so on and so forth. So it's extremely important, and it's a controlled substance because it's an anabolic steroid.
And you said there's a period of time in which you don't have any testosterone, other than that spike that you see, and then you get it once you get in puberty.
Yeah.
And when you get it in puberty, I mean, I would imagine it's going crazy, right? It's going wild.
Yeah. We've all met 15-year-old boys.
Yeah. And the hormones are just raging.
Yes,
We've
they're
both been 15-year-olds.
Yes.
It's been a while, but
actually, it's said about men that we're always 15-year-old boys.
Mentally, maybe.
Yeah, right. From the neck up.
Well, you talked about levels then. What are some of the what's a normal level of testosterone?
That's a great question because not most, but a lot of men that come into our practice, for instance, know what their testosterone level is. Now, typically what they're talking about is what's called their total testosterone. And we'll talk about ranges in a second. There's a protein called sex hormone binding globulin to which most testosterone is bound. So the key number is really the free testosterone, the free circulating testosterone, because a lot of that testosterone is bound to protein. But the raw number that most men know, the normal range, which is pretty much set by the FDA and insurance industry for the most part, is anywhere from, let's say, 250. This is the total testosterone now, up to like 900 to 1100, which is a ridiculous range because basically what they're doing is they're comparing you and me to 18-year-olds and 80-year-olds. You know, an 80-year-old will have a testosterone level of 250, 300. An 18-year-old very definitely is up there in this 800 to 1100 range. And men go through andropause, just like women go through menopause. And as we get older, really the main difference is that women go through menopause very quickly, very acutely, within a year or a couple of years. So they feel the symptoms of menopause very acutely. Men go through andropause slowly. It takes us 10, 15 years to take that whole journey. And so we just get slow, stupid, and fat over a very long period of time. We don't really, although if we did it as fast as women do, hot flashes and all the other stuff, the mood changes and all those other things that occur with menopause would be occurring with men in andropause. So that's a long answer to your question, but normal ranges are from about 250 to about 900. But that, like I said, is comparing men of every age.
But what are the effects of low testosterone?
Well, what happens as we get older? We lose muscle mass. The average male, after they go through andropause, loses about 10% of their muscle mass every 8 years or so. That's called sarcopenia. We talk a lot about osteopenia and osteoporosis in this world, but we never talk about sarcopenia. We lose bone mineral density, just like women do. There's a lot of commercials and a lot of media attention to osteoporosis in women, but men become osteopenic and osteoporotic as well. Cardiovascular effects of low testosterone are profound. If you take a man and you optimize his levels of testosterone post-andropause, you're going a long way towards ameliorating his risk for everything from heart attack to dementia, to sexual dysfunction. In our practice, we do a lot of work with erectile dysfunction, and most of it is age-related, and a good part of it is related to that drop in testosterone that occurs as we get older. So a lot of the ills that befall us as we get older are a result of this hormone withdrawal. I mean, think about it. You went on a weight loss journey before Christmas. You lost 30 pounds over however long you lost 30 pounds. As we get older, we lose muscle mass. We lose about 10% of our muscle mass every 8 to 10 years or so. As we lose that muscle mass, we're losing the principal calorie burning tissue in our body, so that the resting metabolic rate, or the number of calories that we burn every day, just sitting in a chair, like we're sitting in a chair right now, the number of calories that our lungs burn, our heart burns, our kidneys burn as they're just doing their jobs, that's your resting metabolic rate. Well, most of those calories are burned by muscle mass. And if you're losing muscle mass, that resting metabolic rate, let's say it when you're 40, your resting metabolic rate is 2,000, 2,500 calories. By the time you're 55, it's 1,200 calories. So what happens? We turn into an apple, right? Because our muscle mass is not as robust as it was when we were younger. And so that resting metabolic rate drops. We continue to eat the way we always eat, especially men. Think about it. Think about the way you ate when you were 25.
Oh, and I wouldn't put weight on.
Oh, you could skip a meal and you lose 5 pounds,
I don't eat half as bad as I did when I was 25, and I put weight on much more easily.
Yeah.
But that's metabolism, right?
Well, that's what determines your level of metabolism. It's your muscle mass for the most part. And our brains burn a lot of calories, but they're small by comparison.
I've heard the expression now a few times. I've only heard this maybe within the last 6 months, and never prior to that. Is that sitting is the new smoking? What?
Yeah, well,
have you heard that?
It's not good for you to sit all day.
We actually heard it last night.
Did we?
Jake.
Oh, really? Yeah, I didn't hear that.
I'm like, sitting is the new smoking. Come on, smoking is terrible for you.
That's right. My son said that because he bought himself a stand-up desk, and that's what he did say that.
But that can't be a true comparison.
Oh, of course not. But it's it's motivating. It's motivating to keep people moving. You need to move. Even mild exercise on a daily basis is good for you, not to mention the fact that it's the best antidepressant on the planet. And because of COVID and politics and everything else, we're all depressed, and it's very helpful to just move a little bit every day.
Well, for some, that's easier said than done, though, right?
Yeah, sure.
There's cold weather. Mm-hmm. There's gyms that are either not open or open with very, very, tight restrictions. So the exercise that we used to maybe take for granted up until COVID is now a little bit more difficult to attain.
Yeah, it's more of an effort.
It
no
is
question
an
about
effort.
it. There
are apps, though, you can buy and do at home. You just need a few dumbbells and we do.
Leave my friends out of this.
Yeah, I was going to say, the world's full of dumbbells. just go outside to the sidewalk.
That's what I'm trying to escape from. Right? You said a little while ago, and I hope you don't mind me going there right now, but you have me intrigued about testosterone in women?
Yes. Yeah, we're going to talk about that because we're going to talk about estrogen later, but women need testosterone. It's critical to, again, maintaining muscle mass. It's critical. A woman without testosterone has no libido. It's critical to sex drive. It's clearly shown that optimizing testosterone levels in women become anorgasmic, meaning they can't have an orgasm if their testosterone drops to nothing or to a very low level. So it's extremely important.
What would cause that?
Menopause. Menopause. It's one of those things that we lose. Now, that being said, menopause refers mostly to what happens to a woman's ovaries. They stop making estrogens. But as we get older, all of our endocrine glands fall off in production to a certain degree. A woman's testosterone is mostly made in their adrenals, and their levels drop off as they get older.
Interesting. Yeah. I just, I guess it's not often associated. I'm talking about testosterone.
Sure.
Associated with women.
Yeah.
Oh.
Talk to a woman bodybuilder sometimes. Some of the people who come through our practice for body composition analysis, some of these bodybuilding women use testosterone, and you can always tell because as they're coming down the hall, they're talking like this. It really does change a lot of things about if women who are using a lot of testosterone to affect muscle building. So,
but a normal level doesn't change your voice.
A normal level just allows you to build muscle and maintain muscle mass.
And a normal level doesn't make you build like muscle. Like a woman won't look like a bodybuilder if she's taking a normal amount of testosterone.
She won't.
No.
It's a myth.
That's a relief. Folks, you are listening to HyperFit Radio Show. I'm Gary Byron, joined as always with Dr. Guglin, Francesca, his wife. We talking a little bit about testosterone this morning. When should someone be seeking? Well, let me ask you this. I think this is probably more appropriate. I heard this, so dispel this if it's false. Testosterone replacement therapy, does it put you at risk for prostate cancer?
Well, short answer to that is no. It's a myth that's been around since the 1940s and 50s. There was a surgeon, a physician. He's thought of as the father of urology. His last name is Huggins. I can't remember what his first name is. His name is Huggins. He did a study. I can't remember the details of the study, but he did a short-term, not randomized, just a regular observational study on 4 different men, and he gave testosterone to 2 of those 4 men, and one of them got prostate cancer later in life. And the take-home message for him and in medicine for the rest of eternity was that testosterone causes prostate cancer or is at risk for prostate cancer. That's what's known as a confirmational bias. I don't know if we talked about this before, but confirmational bias basically means that the first thing that you hear about something is the thing that you retain for the rest of your life.
Like a preconceived notion?
Why do people tell you to eat carrots?
Oh, yeah, for your eyes, right?
For your eyes, right?
Yeah.
Okay.
Probably has nothing to do with your eyes.
It's got nothing to do with your eyes. This all comes, and this is a story I heard in a lecture. I'm not sure that this is true, but it tells the story of confirmational bias. Back during World War II, when the British invented radar, they were shooting down German planes wholesale. And the British Secret Service floated. And of course, the Germans wanted to know why all of a sudden they were losing all their pilots. And the British Secret Service floated the rumor that their gunners were eating a lot of carrots, and carrots are really helping their eyesight. And so their improved vision was helping them shoot down German planes. And that is the confirmation bias that has been in the culture about carrots ever since then. Now, I heard this in a lecture. I don't know if it's true or not, but it definitely tells the story of confirmational bias. That the first thing we hear about something is what we retain for most of our lives. And physicians are no different than the average human. They have confirmational biases about a lot of things, and many of them about this stuff too, much more so about female hormone replacement, which we'll talk about at another sitting. The fact of the matter is there is a model called the saturation model that clearly shows, and this has been studied ad nauseum for the last 20, 30 years. The saturation model says that once a man's total testosterone level is above 250, which is, by the way, is the break off of low normal. Okay, once a man's testosterone level is 250, every single cell in his prostate is saturated with testosterone. So no matter what I do with your serum testosterone level, once it's past 250, your prostate doesn't even see that extra testosterone. So, and we also know this, that if you take 100 young men, 50 of whom have relatively low testosterone levels in youth, and 50 of whom have normal testosterone levels in youth, the ones whose levels are below normal or considered in the low normal range have a much higher risk for prostate cancer as they get older.
Oh.
Yeah. Yeah.
What is then the relation between testosterone and prostate?
The prostate is tissue just like anything else. I mean, the prostate develops, undergoes a relative amount of development once your testosterone levels come up. But aside from that, the relationship, the prostate with testosterone is no different than all the other cells in your body. And by the way, every single cell in your body has testosterone receptors. So it's really no different. That's probably the baseline point here when I say that it does not increase your risk for prostate cancer, and because your prostate's no different than any other tissue in your body in terms of its level of testosterone receptors.
You talk about levels of testosterone, and I can't help but listen to this, and my mind starts to wonder as you're talking, and please forgive me, I'm thinking to myself, will I get to a certain age where I no longer have testosterone?
No, you'll never get to a certain age where you have none.
You had me scared there, Doc.
Yeah, but you will get to an age where you don't have enough. How's that?
Enough for what?
Okay, here's some facts about testosterone and what we call optimization therapy in our practice, okay? If you take a man who is andropausal, in other words, his testosterone levels have dropped off to a low ebb, and you optimize his levels, in other words, get them back, his free testosterone now we're talking about, you get them back to where they were when he was 18, 20, somewhere in that range, his cardiovascular risk, his risk for cardiovascular events goes down significantly, risk for dementia, senile dementia, risk for Alzheimer's disease goes down significantly. All of the cognitive decline basically stops and reverses. Osteopenia, osteoporosis. We talk about weight-bearing exercise. It's important to do weight-bearing exercise to maintain bone mineral density, but you are not, the best you can do with that is get your bone mineral density to plateau if you're lucky. If you want to maintain bone mineral density and muscle mass, we've already talked about that, you need to have optimal levels of testosterone into old age. Sexual function. Old men have erectile dysfunction. It's as simple as that. You need a certain baseline level of testosterone for that part of your body, for that part of your life to work the way you want it to work. What have I left out?
Is that where like Viagra and Cialis comes in?
Well, they've got nothing to do with testosterone levels. I mean, Viagra and Cialis are basically vasodilators. In other words, they dilate blood vessels and they help you get an erection. They do come in when a man has erectile dysfunction. He's looking for some remedy to that. That's where they become a part of your life, yeah.
But you still need to have a base testosterone level.
Yeah. I mean, there's no question. I mean, how many 28-year-olds do you know that can't build muscle when they go to the gym? How many 35-year-olds do you know that can't have an erection when they want one? You know, that kind of thing.
But I worry about being 70, 75 or older, where, I'm sure a lot of men are nervous that they will not be able to perform at that age.
Yeah.
You don't have to be 75 not to perform. Your testosterone starts depleting in your 50s, right?
40s, actually.
40s.
Oh, boy.
Yeah, you guys are screwed.
Yeah. Well, you're a little older than I am.
I'm a lot older than you are.
What do I do? You can't prevent aging, right?
No, you
so
can't.
what are something?
I mean, most men call us when they're gaining weight. They can't lose their belly fat. They can't build muscle in the gym. They're tired all the time. They have no energy.
Brain fog is a big one.
Brain
also.
fog, and that's kind of one of the first symptoms, I think, of testosterone levels dropping in a man.
Oh, okay. Well, the things. This is why this show is so important, folks. By the way, if you've got a question that maybe you'd like to have answered right here on the airwaves, we'd love to have that question answered for you. Maybe even as soon as next week. Simply email Dr. Guglin at hyperfitradio@gmail.com. I want to be clear, though, excuse me, that this email address is strictly for questions pertaining to the radio show. If you've got questions that you'd like to ask Dr. Guglin personally off the air, I'm going to provide you his phone number as well as the website that you can contact him directly through. I'm sure he'd love to sit down with you and make an appointment or have you come in or however. But if you'd like to have a question answered right here on the radio, again, email us at hyperfitradio@gmail.com. Hey, who knows? You could be asking a question that a lot of others are maybe are afraid to ask, but would also like to have the answer to. So you don't even have to use your real name. You could leave initials or just make up a name and probably benefit a lot of people. I promised you a phone number, though. If you'd like to contact Dr. Guglin, very easy to do so. Just give him a buzz at area code 203-890-9777. It's a very easy phone number. Area code 203-890-9777. And you can also check out the website. I always start there. HyperFitMD.com. It's that simple. www.hyperfitmd.com. All right, listen, I'd like to pick up on this, maybe more of this next week. This was really informative, and I think there's still a lot more to explore when it comes to testosterone and all that. So for Dr. Charles Guglin, I'm Gary Byron. Until next week, have a good one, everybody. So long.
Cool.